tumors. And we meet every 2 weeks with a lot of physicians, hepatology, oncology, radiologists. We discuss the case. And actually, very soon we are cleaning just for HCC from Dr. Malik. I think the other thing is recently our institution merged with another big institution. We're having a lot of referrals, and that's why you are going to see some data I'm going to tell you. It's a little bit different than the average. If any question in the future, you can see my email over there. Focus only just to start this conversation with you about HCC, about the stage. When the HCC is seen by us from the surgical standpoint, obviously when it's most likely could not be surgical treatment. So basically we are talking about stage AC by the Barcelona or a child's pure AV in the majority of the cases. So basically we are seeing patients with early stage or very early that we say is HCC with one or up to three tumors. However, we have different types of patients. They are not falling in this category. Basically, what we do is when there is a single, if the patient has portal hypertension, obviously, most likely is going to go for a liver transplantation. However, there is small numbers that they can go for resection. I'm going to explain you why. Since 2 years ago, one but less than three nodules, obviously with portal hypertension, most likely 99% is going to go for liver transplantation, but there is associated diseases, including the age, and it's not like a disease, but it's advanced age, but there is another morbidity, mortality, risk factors for survival of the patient. Obviously, we do like a strategy, a surgical management prior to go maybe to transplantation or not. So whatever we do, surgically speaking, in this category of this patient, so the survival is not bad. It's about 10%. We are the average survival rate in this category in USA. In the other hand, when a patient is advanced, obviously, Dr. Mal that because goes basically management. And we have the potential that is in charge of radiology, Y90, chemoembolization. So I like this slide because it's just from 2000. That there's the guy, the ASAL. Basically, we follow and we discuss a patient with HCC, the surveillance, the hepatology. But they said before when we tumor board conference in our hospital to localize, identify, talking about LIRADs. 1 to 5, so basically 5 is confirmed, but the main problem is what we are doing with this patient in LIRADs 3 and 4. So basically for LIRADs 5, most likely is going for transplantation. There is another way for. So we use patient, and we have different strategies to make sure this patient has or doesn't have a real HCC with biopsies, that MRI, multiple, and different ways. So, but just to make this with a radiologist, that obviously need to be biopsy in a majority of the cases because the quality of the multimodal CT or MRI fall in this criteria that isn't needed. However, many of these patients can go for biopsies as well or laparoscopic diagnostic that is going for the stage. So we have an HCC patient identified, so patient can go to resection, yes or not. If he going for resection, basically these are no cirrhotic patient, child A, majority of the patients single lesion. I'm not talking about the size, only single number with no mets. All these patients falls in this category. I'm very happy to go to this patient with different modalities, robotically or open or laparoscopic technique. The problem in this category, this patient, is because we are referral center with a new system that we have with a new company that merged with us. We are getting a lot of patients pre or early cirrhotic or cirrhotic with big tumors. So basically, we are patient until we finalize it is a transplant candidate or not. If it is not, the surgical management of this HCC is to downstage to go to the Milan criteria and then go for transplant. Actually, the majority of this patient goes transplantation. Obviously, this patient is a transplant candidate, goes for the known way to go, depends on the number or size or portal hypertension or not of the patient, different story. And depends on the MEL score, depends on the morbidity, mortality. Also, in between, patient can develop a recurrence of more HAM or HCC. We tend not to operate this patient. We do only regional therapy in the majority. We are radiology. Why? Because our goal is for the patient is not a transplant candidate, different morbidity or more tumor advanced for it that they basically follow the patient. Only like an example, sorafenib, but I know there is other drugs that he is using. So this is basically the algorithm. Probably you had the same, but for HCC treatments, I went to 4 different hospitals. Hospital has different approach, depends on how they are having the equipment or how the experience. So basically we do liver resection, this or go for liver transplant, easily for HCC. As a bridge for transplantation, or doesn't qualify for liver transplantation for any other reason. The cases I'm going to tell you, endoscopic or robotic microwave ablation. Every year or 2 years, we update our technology and we have in the latest. So our rate to cure or control cancer for 3 to 5 years, actually, I have this data because we are in US data going to make you take a little bit more frequent. It's very high. It's about 75% we are controlling tumors in general. If we do chemoembolization, that is done by radiology, and we combine with microwave ablation, so go 95%. That data is from hepatology. They following this patient. So we have a very good control only with these 2 techniques. Now we have a new one, not new one, but we have another one that is Y90. That is, I don't have the data. We combine a liver ablation or we combine the other 2 is to control all recurrence patients. In the other, I came here, we were using our technique, become a little bit more tedious in terms of that. That's why liver ablation, but it's Hepatology is still doing, but in few cases, ethanol injection and other injections do, but it's less and less and less. I think they like more Y90 than the other ones. Another HCC therapeutic option is, this is known biological and gene therapy. I was reading an article yesterday just to see today. It was hundreds of genes identified, but right now it's, I think, 32. They are working in biological gene therapy. That is very exciting, to be honest, if we identify. The problem is, I think they already applied to the FDA to use that. However, because the diversity of risk factor for HCC about if it's local, if it's a first generation migrant, or if it's not age, basically, if it is race, etc., or Hep Hep C, etc., they make a difference. So I think they start using the kidney transplant successfully, not in all of them, some selected patients, and they are planning to be approved, so heads up, in August this year, but I don't know too much. We cannot discuss that because, okay, it's not totally approved for HCC treatment by the FDA. Systemic chemotherapy, Dr. Malik's medical management with a lot of different ways to treat this HCC. Basically, this is all the spectrum that we have to treat this HCC in our patient population. So what do we have here? So we have mainly, as I said before, having referred from cirrhotic or early cirrhosis patient. 70–90% of the HCC diagnosed is associated with cirrhosis. Obviously, depends how is the hepatic reserve. We can do something in the patient. If tolerates resection, it doesn't, it's not going to go over there. We trying, I'm not going to define, but the underlying cirrhosis, a pre-malignant condition, depends what type of infection, like Hep Hep C or other risk factor, depends where the patient lives geographically in another areas. Or as in USA, we have first generation patients coming from another countries. We can just categorize like a pre-malignant condition, or we follow this patient very closely. Multifocal tumors is very common here. It's about, I can say, roughly 60%. But all of them, they are questionable HCC. They go to LIDAS 1 to LIDAS 3, sometimes LIDAS 4. And in this case, we are very easy and very fast to diagnose. We go to the diagnostic laparoscopy or robotics, multiple random liver biopsy. At the same time, we do liver Doppler ultrasound in OR to make sure that veins, they are open or not, or they are involved. We use a BK ultrasound that is very good quality to take lymph nodes, biopsies, etc. And we discuss the results after that. So what happened is we do that because basically as a referral center, many of these people bring CT, no multimodal CT or no multimodal MRI. And when we read here, it's underestimated the imaging study. And this patient had a kidney problem. We cannot repeat years right away, but we need to do something with this possible HCC. So the main question is, we're receiving a lot of patients with HCC with cirrhosis or liver transplant cured cirrhosis and the cancer. These are always the question that the patient is asking, probably for you as well. Well, does it work? I usually say yes or no, depends how is the situation, but it works. I can say yes, it works. As an example, I was training in Pittsburgh, so I'm very fan of Dr. Tumor Starset. So this is one of the transplant patients and then that survived for 41 years after HCC. In other words, yes, let's do liver transplant in somebody with HCC. A patient can have a normal life. Yes, so this is a typical example to see. Other studies basically said, obviously, the survival rate in liver transplant after HCC is good. So depend. This is all the studies because I put in this all the studies for one reason, because at that time we didn't have too much technology like we have right now. Right now is better than this number, is higher than this number that it was published at that time. Talking about liver resection HCC in patients with cancer. So right now, since a year ago, since the liver allocation system changed it changed not in favor of the HCC patients. Why? Because, for example, 2002, 2004, patients with HCC stage 2, they got a transplant when they have MELD score about 29 average, 2004, 24. But right now, we don't know exactly how it's going to be because the new allocation is follows in the category of the median MELD score from the area. That's a number of the MELD score, and we rest -3 points, and that's the MELD score of the patient that have to be in the list for liver transplantation. Example, so in my hospital, in my area, we are doing liver transplant with high MELD score, low MELD score, but the average is at 30 MELD score going for liver transplant. If we rest -3, HCC patient can reach the highest MELD score for HCC is going to be 30 -3, 27. So let's go to New York. That is about 60, 78 miles away from my hospital. The median MELD score for a patient going for transplant is 31. So resting -3 is going to be 28. So New York has 28, and we have 27 to do liver transplant with HCC taking the MELD score. Only 1 point makes a lot of difference. So you can see my patient with MELD score 27 with a patient with New York with MELD score 28. There are like 100 patients right there. So my patient is not having a transplant nearby. So, but this is not happening in here or in New York. It's happening in all USA. In the majority of the programs, they are not doing transplant too much with HCC diagnosis. So they are adopting different strategies. Some they are improving, they expanded the DCD criteria for donor. They have a Hep-C, they have a living donation, but always there is a shortage of donor. So we are doing a strategy right now. We can make a comment later. So basically, we are following the criteria that you know, stage 2 HCC, 1 tumor less than 5, or 3 tumor less than 3, with no vascular invasion. That qualifies basically for liver transplant. That is the main problem for HCC and no resection or resection in the cirrhotic patients. So, however, as I said before, that is changing mentality, different people in different area. Yes, we are going to have a transplant meeting next month. There is going to be a lot of talking, I think, behind the corners about what to do with this. So we need to increase the size of the tumor without microvascular invasion. Some people, they are doing transplant oncology is another topic that is going to be very popular very soon for liver transplantation and for liver resection as well. I think Dr. Fong started doing transplant oncology. So for colon cancer with liver mets in the tumor, instead to resect, he is proposing to be transplanted. Can we do some other potential curative operations, not based in the size of the patient? So this is talking about risk factor coming from. So it's a combination of gene, risk factor, geographical factor, and infection factor, and that could be correlated with the size of the tumor. Yes, now because we saw tumor I'm going to exaggerate a little bit, like 1 centimeter, very aggressive in less than 3 months, is all over the liver. We saw tumor like a 10 centimeter after a year didn't progress well. So there is obviously something that we can think and identify. Hopefully that answer is going to come soon. So a strategy for HCC patients. Obviously, if this patient with child A cirrhosis with preserved liver function, we can do, or also we can do a liver transplantation if the HCC recurs. This is probably the most common strategy that's going to happen with actual MELD score that is not in favor in our patients. But what is the definition of preserved liver function? In general, this is a controversy. It's not a standard. So basically, mild or no portal hypertension. I say no portal hypertension here just for general conversation. Mild or no ascites, mild or no varices, playlist. Some people say 80, some other people say 100, depends what institution you are. Total Billy is not a standard as well. In my hospital, we're using 2, I think. I put 1.5 because this slide is a couple of years ago. We expanded our criteria. And a pressure in the IBC just to make sure that potentially portal hypertension. So in my hospital, we have the 2 options, open or minimal invasive surgery. In the minimal invasive side, we have the robotics or the laparoscopy. Which one is going for HCC resection depends on the localization, depends on the patient, body habitus, many different options. We do the other thing, no resection with the robotics and laparoscopic as well, like a liver ablation. Also, combine, as I said before, the robotics or laparoscopic with radiology for the chemoembolization. I don't have data too much about the white night. I have few patients that when they had a white night and went for surgical management of the HCC. I cannot tell you exactly how good it's going to be or is being right now. All situation in the past, big incision is already replaced by the small incisions. In the right side, this is a patient candidate for liver transplant. What we did is a liver ablation by laparoscopy with a small tumor in the left lobe, and this is a follow-up, well controlled while it's waiting for liver transplantation. One second, I think, yeah. So what we're doing here, so this is the cases that I have. So obviously I have in the item orders, there is like a 10, 15 different, but they're more frequent. What are we doing in the malignant lesions going for surgical treatment? The majority, as you are doing, is HCC. Secondly, we do meds from colon cancer. We are not a breast center referral, but still we have some patients with meds from breast cancer. They usually associate with another institution, but still we are having this. We created a HPV unit like 2 years ago. That number was 0% 2 years ago. Now it's getting better. It's about 5%, growing in year by year. Cholangiocarcinoma is still low. We are not a cholangiocarcinoma referral center. Hopefully we will do in the couple months or years. But still we having this kind of patient. Sarcomas, mets, that, and other miscellaneous. For the benign lesion, we are having a lot of patients with symptomatic liver cyst. No parasitic is only no parasitic cyst. Symptomatic FNAH and adenoma, they are the second one. I think adenoma is a little bit more than FNH, but FNH could be the same. This data, and Dr. Mali has more than me. What they were doing FNH adenoma, so majority of people say, what are you doing with these guys, surgically speaking? The problem is, I think there is some data. Some people are considering adenoma like a pre-malignant, depends on the risk factor. And FNH is, I say usually to my residents, a pitfall as diagnosis because we have to go to make a diagnosis in the OR because even we do MRIs or CT scan, sometimes it's a questionable and questionable. If the patient has an early cirrhosis or some risk factor to have cirrhosis, obviously the risk to have HCC is a little bit higher. And that's why we intervene and we do surgical management. Hemangiomas, usually we do the symptomatic giant hemangiomas simply in the right lobe. We usually do resection of these tumors. Gallbladder masses, no cancers. There is a couple of them. I don't know the population coming from different places. I did like a couple gallbladder masses. No malignant pathology results that I didn't see that in Pittsburgh when I was there. And other benign pathologies. That is basically the majority of the cases that we're managing and increasing in numbers in our institution. So liver resection for HCC, open or laparoscopic. Obviously, nobody has a real answer. It depends where you are. It depends what the sources that we have. In fact, the minimal invasive surgery actually is demonstrate that it's much better. Again, this is all data without too much technology at that time, but now the number they are much better. Survival rates is basically a little bit better or no statistical significant, no statistical significant in both of them. That's why I say it depends what the equipment that you have or the experience that you have or referrals that you have. But you decide to do a laparoscopy versus open, obviously, my pathology is crazy about the surgical margins that they think that doing minimal invasive surgery because we are not touching the tissue is going to be a mistake. We are combined when do surgery for minimal invasive surgery, we combine with ultrasound BMOs, and we have good margins as well. I didn't have any recurrence of the liver research by robotic or laparoscopy. And the other data is basically the same like the other published. However, I can say in general, I think minimal invasive surgery for HCC surgical treatment is a superior, I can say, depends on that, compared to the open technique for many reasons, okay? But it's not a gold standard probably for some patients, but it is a big option. Now with the robotics, it's getting better. Same situation, laparoscopy versus open, you know, recovery time, EBL, blood transfusion, length of stay, and OR time is better in doing minimally invasive surgery. I'm here with laparoscopy, with the robotics. I don't have too much data to show, but it's very similar to the laparoscopy. You know, some patients cannot go for laparoscopy. Either patient has morbidities or some patients, they don't want to go for any personal reason for transplantation. Obviously, we do laparoscopy. This cirrhotic patient, typical cirrhotic patient with a tumor that we resect by that is resected by laparoscopy with no problems. But again, we have to make sure that both hypertension, platelet, etc., and that reserve of the liver is in good pattern. I have videos, but for some reason it's not loading up. Finally, after the patient went for surgical management, total Malik team and we follow the patient periodically. And this is a typical patient that we still, after 6 years, still following with 6 months of yearly CT scan and with no recurrence. This patient was done with free biopsy, with minimal invasive surgery, is still there. The difference you can see is not cirrhotic, and that is the good thing in this patient. Conclusion, I think for HCC, stage 2 liver transplant is still being an excellent option. However, I put like a first item here because I think we are going to change our strategy to, surgically speaking, for HCC after this liver allocation Medescore system changed recently. That is not in favor for liver cancer patients with cirrhosis. Minimal invasive surgery is the first option. Also, consider a bridge for liver transplantation. Resection by laparoscopy or robotics, obviously select patient with experienced team. There's a lot of things going around on the patient. I think to do a liver resection with solitary HCC with child age cirrhotic patient is the typical patient that we can do with minimal or open surgery with good results. Thank you.
Thank you, Eli. It was a great presentation. I just want to kind of give you a little bit of background from Bangladesh perspective. Like Dr. Atik mentioned, we in Bangladesh we have not had like a liver transplant setup or infrastructure. So there's some liver transplant we had by some of our surgeons. So primarily the treatment is mostly geared to either resection or microwave ablation. And most of our patients in Bangladesh, and Dr. Rabbi and Dr. Das can can give us more idea about that are Hep B with liver cancer. So they are mostly non-cirrhotic. So the only treatment options are either resection, ablation, or other local regional therapy like transarterial embolization. I don't think we have Y90 in Bangladesh yet. So I'd like to hear from Dr. Das and Dr. Rabbi, and to kind of hear about what we do in Bangladesh so that we can share with Dr. Sebastian. And of course, any questions for Dr. Sebastian, you have. So start with Dr. Rabbi first.
Thank you very much, Dr. Malik and Dr. Sebastian, for your nice presentation. And Dr. Ashraf Malik has rightly mentioned that we don't have a established liver transplant program here in Bangladesh. Just few sporadic transplants by different institutions in different institutions, and 3 of those transplants were done in our hospitals, and 2 are one for hepatitis B virus, 1 for cryptogenic, 2 for cryptogenic liver cirrhosis, mostly NASH. So those are only sporadic transplants done with the help of our Indian friends. So we actually mostly deal with HCC, and HCCs are mostly present to us in an advanced stage, because even in US and Japan, scenarios are different. So far I remember the data, it is only 30 to 50%, I think, is resectable in US, and moreover, due to good surveillance program in Japan, is that the resectable lesions are only 60%. But in our scenario, in our hospitals, in our setups, that scenario is totally different. Most of the patients presents to us in advanced stage, going in different hospitals, rejected by different surgeons for surgery, later come to us for surgery. But we can't do surgeries in all patients. Dr. Malik has rightly mentioned, we also encounter a good number of patients with HCC with non-cirrhotic liver. We don't have any option just to go for resection, even in cirrhotic patients. The most important thing is that, so far I remember, in our data shows that most of the patients presents to us more than 6 centimeters lesions. So in those cases, we face that the lesions are mostly having vascular invasions, and when we assess the patient, we face that the cirrhotic patients mostly presents to us with ascites, and with grade 3 and grade 4 varix also. So we face a different scenario to make a decision for resection. So in that cases, I have few questions to Dr. Sebastian. So what should we do in these scenarios to prevent post-hepatectomy liver failure?
Excellent question. Actually, yes, Tomali was talking about transplantation issues. We talked in some points before COVID, we're thinking, let's go over there. But COVID came, and that's a problem. So basically, that situation happens to us too. If a patient comes, if a patient it has ascites, obviously has portal hypertension, and the patient doesn't want to go for liver transplantation. So it directly goes the patient to a liver ablation combined with chemoembolization. So that controls, as I said before, at least in our hospital, 90-95% of the cases. So the problem is a big tumor, as you say, 6-7 centimeter. Probably I'm very curious about how is going to be the risk factor for HCC in your area, because it changed Japan, USA, Mid East, depends, because you have different cases, scenarios, and risk factor as well. So obviously, you're not going to deal with the risk factor, you're not going to treat the risk factor, but you have in front of the patient with HCC. So I probably would suggest in some case to do, yes, to control the tumor. We did the same situation here, but we did the ablation not in one session. We did like 2 or 3 times every 4 or 6 weeks, combined with the chemoembolization if the patient tolerates. But to do a liver resection in somebody with cirrhosis, with portal hypertension here, unless the tumor is bleeding or is something that the patient is going to die in the next week, we can do something just to control the emergency we do. But usually we don't not do resection in this kind of patient because, as you know, morbidity mortality is very high. And you see for the Barcelona, for the AAS-ALD as well, they are not a good outcomes in that kind of patient. Sorry, I didn't hear. Do you have a microwave or RFA in your hospital?
We have access to microwave and microwave ablation and RF infused centers, though we don't have in our hospital, but we can access in those setups. But my question to you,
yeah,
sir,
go ahead.
sorry.
No, go ahead. Sorry.
Okay, my question to you: how to prevent this post-hepatectomy hepatic failure? So, what should we do in this kind of situations? Or as these are the patients who are more liable to go after liver failure after the surgery. So how to deal if it's a huge lesion? So we don't have any option but to deny surgery. But if it's a resectable lesion, how to prepare? Because I am having the same kind of patient. Patient is admitted in under my care, and for last 2 months, I am unable to control the huge ascites. I have already done tapping nearly seven times just to get rid of those ascites. The patient is having repeated bouts of respiratory distress due to huge distension of the abdomen.
Well, probably will defer a little bit to Dr. Malik that question because usually when we have this case presentation, we ask the hepatologist to control the ascites for different ways, medical, if it's a candidate for tips, etc. Because I know it's a big problem with ascites and dual liver resections. Personally, if patient is cirrhotic with portal hypertension with recurrent ascites, I'm not going to do a liver resection, plan a liver resection unless there is a bleeding or something like that. Actually, do you have any? I think it's an interesting question. It's a very good question.
My patient didn't have ascites before the surgery. She developed the ascites later after the surgery.
So you have this. If you have ascites, so patient, what I understand, Dr. Rabbi, that patient had initially had a like child PO cirrhotic with the tumor in the liver and had a resection, but developed decompensation after the surgery. That was the question. Yeah, it can happen. It can happen after surgery, of course, after resection, depending on how much resection patient had, and depending on what was the liver function prior to the surgery. And if it does happen, it all depends on what's a patient's bilirubin and INR, something called, as you know, the MEL score. So one option, if you're having recurrent ascites and paracentesis, if the patient has
she was on child A.
No, after you said after decompensation, what is the patient's bilirubin and INR and sodium level?
Liver function is almost normal, except the ALT is around hundreds. It's around 130 or 200, but prothrombin time is around 1.5, 1.3. It's like that.
I know. So what his sodium level is?
Sodium level is 136, 135.
Okay. So I'm assuming his MEL score is the patient's MEL score is low. So one option would be TIPS, transjugular intrahepatic portosystemic shunt. If the patient does not have an encephalopathy, then TIPS is an option to control the ascites. So the ascites, patient with refractory, I'm assuming this is refractory ascites. If they have a relatively preserved liver function with the bilirubin, usually, you don't want to be above 3. If the INR is normal or near normal, and then normal or near normal sodium level and normal renal function, which makes the MEL scores low. So usually cutoff is, we can somewhere between 15 to 18. The transjugular intrahepatic portosystemic shunt can control the ascites, so patient can benefit from it.
Thank you very much. And another question I want to ask, especially to Dr. Malik, that with the resectable HCC and hepatitis B high viral load, how do you approach this kind of patients?
For hepatitis B, treating hepatitis B or? So
hepatitis B virus positive with high viral load.
Yeah, high viral load in a patient with a high viral load, you need to treat that indefinitely. So you should treat that for, I don't know what available knowledge, I'm sure entecavir or tenofovir would be the choice. So patients should be on it even before surgery, after surgery, and continue indefinitely.
How long do you wait to, is there any cutoff of the viral load?
For cutoff for what?
To go for early resection or something?
No, a resection should be, no, you shouldn't wait for the viral load to come down before you resect it, unless you're concerned about, like, during surgery, if you're concerned about, patient, because you're going to do, if you have the surgery, patient is going to have the surgery, of course, you have a bleeding and everything. So the surgeons and all the surgical staff, if they're concerned about that, there might be a transmission risk. Then you can wait until below undetected level or below 2,000. But it depends on how you don't want to wait too long, because you don't want a cancer to grow further, and then patient may not be resectable candidate.
Yep. Thank you very much.
Dr. Das, if you can share your experience with us and with Dr. Sebastian. And if you have any question for Dr. Sebastian.
Okay, thank you, all members of Planetary Health Association, especially Dr. Atikurjaman and the moderator, you, for giving me the opportunity to attend as a panelist in such international webinar. I also like to thank Dr. Eli Sebastian, the Chief Surgeon, Transplant Surgeon of New Jersey, for clear and informative deliberation of surgical management of liver tumor. And as the Sebastian says, although we have some protocol, international standard protocols, so who will going to receive for resections and who will do for transplantation or other minimal ablations or TACE. There are some international criteria, but it varies from center to center, country to country, because the treatment depends on the facilities available and the logistic available, expertise available in that areas. Similarly, in Bangladesh, as you mentioned, we have actually very limited number of scope of dealing the liver tumors. We have only the resection option. We have a few centers or few people are doing some ablations, and very few centers or very few people are doing TACE. So we have only in our hand is resections and chemotherapy. As transplantation is actually not yet established in our country, although as Dr. Rabbi said, a few cases we have done very sporadically. So what we are doing actually, what the other thing the Dr. Rabbi has mentioned, the people actually who come to us for treating the liver tumor at a very late stage. More than 95% people come to us with the tumor, very high grade volumes, 10 centimeter, even 14 centimeters, with compensated or decompensated cirrhosis. So this is actually, these 90% or 95% people is not actually suitable for transplantation or resections. As we do not have any popular minimal ablasive capacities or facilities. So we mostly go to the chemotherapy or like this. And some people who actually come to the resection criteria, we do the resections. And resection, you see, if the tumor, as the Sebastian says, the less than 5 centimeters size, or the tumor actually located in a a segment or an anatomical lobe and a good underlying liver functions good, or the remnant liver, estimated remnant liver will be good, then we go for dissection. This is we can do, and this is in various centers in countries like BSMMU, Bardem, and Dhaka Medical College Hospital and other private centers. They are doing these sorts of dissections. But and what actually I do in my practice, as most of the tumor come to us in a bigger size, more than 6 centimeter or 10 centimeter, 14 centimeters. What I am practicing now, as we have very limited centers of test facilities and ablation facilities also. What we do, we open after evaluation, we open the abdomen, we cut out, ligate the feeding vessels, we mobilize that loops for disrupting the collaterals, and sometimes we use the alcohol inside the tumors, and the surface tumor is burned by the diathermy. So that is called the sandwich therapy. Although I have not much enough data, we have done in few cases, we have seen the mixed results. So I could not tell you the results of this source of sandwich therapy. We are continue to do this practice, and hopefully in future I can publish, but we can inform the world with the limited facilities what we can do when the patient come in a very large tumor. This is my experience and in what we are practicing in our country. And if the patient come, or our hepatologist friends or other doctors send the patient to us, or we can catch the patient in an earlier stage, whatever the procedures available in the world, and we hope that you see the curative dissections only if the patient comes in an earlier stages, either do in resection or the transplantation. So except transplantation, we are doing in a limited way in our countries. So we need to develop this sorts of referral system, follow-up systems, and if we can have the patients in the earlier stages, then we can apply the standard treatment to our patients. Thank you very much.
Thank you, Dr. Das. There are some questions. There is actually Dr. Rafiqul Hassan Chapel. I think you raised your hand. You have a question for Dr. Sebastian, I guess.
What's the question? Sorry.
No, I was waiting for it to see if you have a question. So while we're waiting for that, actually, there's a question on the forum. Somebody has a question, Eli, for you. Patient with cirrhosis and portal hypertension has a liver cancer. Since the patient has portal hypertension, can the liver resection and the splenorenal shunt can be done at the same time? What is your thought about?
We did few cases. However, we need to go back to our criteria indications. Who is going to go for splenorenal shunt or any shunt? Independent of the cancer. So patient going for splenorenal shunt or any shunt basically is going to have some bleeding or other signs of the severity of portal hypertension. That is definition of what we do. However, if we do combine HCC with splenorenal shunt as a prevention, I don't think it's going to work well, because maybe we can create another problems. However, if this patient falls on this criteria to do a splenorenal shunt, yes, why not? So that's why we have patients here. We did a splenorenal shunt because not the HCC is because the indication for for varices, bleeding, all that stuff. At the same time, with the resection, the difference is it was a tumor in the left lobe of the liver, as you know, and the volumetric measure from the right and the left. So, you know, the left is more easy compared to the right side. I'm not going to recommend it is a big tumor in the right lobe, unless it's a big challenge, because it's not data that is you're going to improve overall. Probably you're going to add a need more a possible morbidity in this patient. So question is, if the patient is a candidate independent of the HCC for shunt, the answer is yes. Okay, you can do it. Or if the tumor is on the left lobe of the liver, yes, you can do. But I didn't see data, or unless you have experience, to do a prophylactic spinorenal shunt for ACC, possible decompensation. I'm not sure about that. I saw different. We did hear a different no spinorenal shunt. The Japanese technique. Oh my gosh, it's in the top of my head. So we did a resection and we did a devascularization from the soft, all that stuff. Still that the patient created a portal hypertension decompensation after the liver dissection. This particular patient didn't want liver transplantation. He wasn't a candidate for some reason as well. But again, you don't have options. I will probably put in plan B, but if the patient doesn't qualify for a indication for spinal shunt independent of HCC, I will not suggest to do that. You know?
Okay, thank you, Eli. I'll wait to see if anybody has any question. Professor Das, do you have any questions for Dr. Sebastian?
No, it's okay.
May I have?
Sure, go ahead. Dr.
Okay.
Professor B, yes.
May I have any comments?
Yes, you can make. Go ahead, Dr. B. Yes.
Actually, I want to supplement Dr. Das, Professor Das's comments that we are doing good number of liver dissections. I think Professor Das also doing the same. We luckily have good number of patients, actually huge number of patients to go for liver dissections. We do good number of benign cases also. And most of the bulk of our hepatic dissections are RPC and with hepatolithiasis. Okay, so I'm just sharing the difficult scenarios we have faced. I just want to ask Dr. Sebastian and share one of my experiences that I have encountered one of my patients who is having a non-cirrhotic liver with 7 to 8 multiple hepatic lesions only in the right lobe of the liver. So during my assessment, I thought it could be a good case for right hepatic resection, as the remnant of the liver is not showing any lesions. But after laparotomy, I have found that I thought it was an 8 lesions, but I have found 14 lesions, including during my intraoperative ultrasound. So I did the multiple hepatic resection, and after the resection, I removed during the resection. So far I remember, I have removed 8 lesions, and I have left a few lesions in the left lobe. But I thought that it would not be safe for the patient. Though I think it may sound crazy to you, but I have left the rest of the lesions. And later, I have after 6 weeks, after 4 weeks, I have reassessed the patient. I have found the remnant liver is having around 4 to 5 lesions, which were not present during the during the preparation or during the assessment. So I did the microwave ablations of the remnant lesions, and she was quite well for 2 months. But regular evaluation, I have again found 3 more lesions. So in this kind of scenarios, as the patient is having a non-cirrhotic liver, what should we do?
So you mean, so just to clarify, so you did a tumorectomy, basically, right? No segmentectomy. So you took the tumors out only, right?
Actually, I did trisegmentectomy this patient. I have removed segment 5, 6, and part of the and 7, keeping the segment 8. And I thought that I could be able to remove few more lesions. At the few lesions were located in the deeper aspect of the left lobe, So I have abandoned the left of the resection. So later I did microwave ablation of the remnants. So what should we do in this case of kind of cases? What should we do?
That's one of the cases I like it to come to me. But no, I think you did the right thing. You need obviously you took the majority of the tumors and then you do the ablation. I would do the same thing. The problem is recurrence. So we don't have a ball magic to say this is going to come back again and again. But remember, there is a technique that you do in 2 steps. Remember, we don't resect anything, just we cut the vessels to make sure the other regeneration of the other lobe. So looks like it happening to you, but you didn't intend to do that. That is because you removed already the other thing. In remnant liver came back. If there is no transplantation, I will probably see how is the volumetric or how the size of the liver remnant. It is still a candidate for do another resection based in the weight of the patient and the volume of the liver. May be another resection to do it, but I will do the same that you did. So just liver ablation in the remnant because we cannot remove the whole liver. So it was a challenging case actually. It's a good case.
So I'm giving you the update. I have sent this patient to one of my teachers, and abroad, they did PET scan. They didn't find any extrahepatic disease. They have asked her for liver transplantation. I think they are considering the liver transplantation.
Yeah, this is the salvage liver transplant indication. This is basically the patient falls in the category non-cirrhotic patient, have a cancer, and then too much tumor was removed and cancer came back. Yeah, there is a criteria for exception for non-cirrhotic patient in this category. Yeah, we have that. We have that too. But I didn't say transplantation because you were talking about a technique but yes, it's a good option for him.
Okay, thank you very much.
Professor Das, you wanted to say something or?
Yes, in Dr. Rabbi's experience, when you open the abdomen, you saw many tumors in the right lobe of the liver and also in the left lobe of the liver, right? So you remove the right lobe and the left lobe tumors, the multiple tumor, you can ablate by diathermy or microwave or reduce ablation in the same settings. And I think the liver transplantation is not suitable for such cases because you see the after ablation even and resection, the tumor recurrence is there. So even after the PET scan is not 100% sensitive or specific. I think this case, if you do a liver transplantation in such cases, the recurrence will definitely comes to the graft liver very soon. So I'm not disagreeing, although I do not have any this source of experience of doing this liver transplantation. But if you see the data, that the liver, when you see the reason why the peoples are following the Milan criteria, although the many Indians are follow the beyond Milan or more these things. So I think you can see for the experimental purpose, but you cannot recommend and definitely that this is a suitable case for liver transplantation. This is my comment.
Thank you, Dr. Das.
Just to clarify, yes. Ashraf, yes, that is true. However, right now, when I said before, the HCC problem in USA is changing the perspective to manage HCC. So that patient that it was mentioned just a couple of minutes ago perfectly falls in the category for salvage or save the patient, okay? And there is exception for this guy. I'm not saying it's the goal stands to liver transplant. However, remember, there is another case that they are trying to do liver transplant in some people with metastasis. That means it's not a HCC. It's coming from another like colon cancer, and they are working perfectly. It's not a gold standard, but again, it is different situation that rarely we can see, and obviously in the future may become. I think with the HCC problem happening right now, all these possibilities going to come soon, and we have more alternative with all these people.
Okay, thank you, Eli. So it was a great discussion. If anybody has any other question for Dr. Sebastian, and Eli, since everybody is here, all the surgeons from renowned surgeon from Bangladesh, I know we did talk about going to Bangladesh, do some workshop, because I think your expertise in microwave ablation and probably laparoscopic liver resection, if you share your experience sometime in the future, hopefully when the COVID is kind of no more issue, I would like you to really invite you to. It's a beautiful country there. I know you, Dr. Sebastian, originally from Peru, so we also are very fan of soccer. So something we can do in the future, like a workshop, and we'll have some. What we'll do is basically have some cases before we go, so you can review the cases, and you can kind of show or share your experience about this microwave ablation, and because this, I don't know how long it's going to take. Hopefully, we'll have a liver transplant standard program in Bangladesh, but until then, still resection and microwave ablation, local ablation therapies is the standard of care in Bangladesh. So something in the future we can do a week workshop in Bangladesh, and all the surgeons, and you can share your techniques and experience. So that'll be something great. So
okay.
say something.
I am actually hello.
Yes.
I actually, as I am working in the university, we are planning. We have also a society of hepatobiliary pancreatic surgery in Bangladesh. We are working in that, and I actually delighted to invite you and Dr. Eli Sebastian to come to Bangladesh, and we have a plan actually to do an international conference in coming October, November. So actually, I through today's webinar, I like to inform you if we could do this workshop or conference in the coming year. I hope we can invite both of you to come to Bangladesh and to share your experience to our surgeons. Dr. Sebastian, I remembered my word. If we could arrange a conference to our countries, I will invite you and also the hepatologist to come to Bangladesh to enlighten us with your experience. Thank you.
Oh, my pleasure, my pleasure. Any time. So I'm very happy to. Yes, I was saying before, Ashraf and I, we were planning to go to visit your country, but COVID just stopped us. But no, it's a good opportunity. There is a lot to talk. Remember, I come from my origin country is Peru. That we had similar situations compared to your country in the majority of the cases. But I'm very familiar with what you're talking about, the problems, what expectations. I was in the transition process in Peru when went from not having this and now having that. Yes, very happy to go and share. Thank you very much. Okay.
All right. Thanks, Eli. Again, thank you very much for your time, and I really appreciate it. For the talk, and if you don't have any other questions, so I'd like to end the session. I would also like to thank Planetary Health Academia for arranging this. Dr. Atikuzzaman, Atik Bhai, one of my favorite person, and all the participants, Dr. Rab, and importantly the panelists, Dr. Rabbi and Professor Das, and all the participants who participate in this session. Thank you very much, and have a good. I don't know, Dr. Atik has something to say.
I would like to tell you that next year we are planning to do a big international conference on various subjects on behalf of Planetary Health Academy in Bangladesh. We will be definitely collaborating with all the organizations and major institutions like BSMMU, because we already have a mutual agreement signed, BCPS, BARDEM. Rabbi is like a younger brother to me, and he's very dynamic and very brilliant surgeon. with all the limitation in Bangladesh, he's doing great work. So what I heard from Professor Dash is very nice that he already invited two of you to be there. I think it's amazing, and that's the whole idea of this collaboration. And in a very short notice, both of you attended, and hopefully we'll be able to do more in future. I think one of the things we have to be working very closely is the early diagnosis of this tumor, because that's where the surgical success depends. So a very good screening program, a nationwide screening program is absolutely necessary. Like the way we do it in United States, all the patients with chronic hepatitis B, we have a very standard sets of screening tools are placed. It's a part of the quality measures. Way before the patient reached to the unresectable stage or liver cirrhosis, we can detect that. And I think that's one of the reasons why resection of hepatocellular carcinoma is a good success here, because the detection is early. So I think that is one area we need to work together with the primary care and the hepatologist in Bangladesh. So once again, I'd like to thank you all on behalf of PHA and our collaborative effect. And thank you, Dr. Sebastian, to join us. And I'm a big fan of Peru. We've been to Peru, been to Machu Picchu, Cusco, and other places. Love Peru. We'll go back again there. And thanks to Rabbi especially, and Ashraf for being here.
You're welcome.
Right, thank
you
you
very much.
Thank you.
Thank you. Thank you, everybody.
Thank you.
Bye bye. Thank you. Bye bye.
Bye-bye.